Hi guys, I'm Kelly Kensick. I'm an epidemiologist. I work in the Institute for Cancer Outcomes and Survivorship. I'm also part of the Division of Hematology and Oncology. I also completed the T32 training between 2013 and 2015 and then moved over to faculty. So Emily asked me to kind of, since I've been working in administrative databases a lot over the last 4 years or so, to kind of give you a big overview of administrative databases and how you can use them in outcomes research. And she gave me a ton of slides that she's given in a bunch of different presentations, so I kind of mashed them together and then threw in some stuff, so I'll kind of give my perspective on some things. The big picture here is just to give you an idea of what are administrative databases in general, what's in them, how to think about using them, and then we will talk about practically how to get them, some of those logistical issues, especially in a either junior faculty stage or a postdoctoral stage, and how you can get access to it. This is definitely not an hour-and-a-half presentation, so I know you guys want to talk about this for an hour-and-a-half, but it's not going to be. So please, if you have questions, and it's meant to be, if you have questions and if you want to talk about anything practical or have any questions, feel free. So what is administrative data? And in general, we think of it as data that is designed to sort of monitor the delivering of care or paying for care. So it's designed for billing purposes for the most part, and it's designed for health systems practically or insurance companies. It's not necessarily generated with research in mind. So they're not generating their data thinking about how we can answer some question 10 years down the road. That's just not how they're set up to be. Has anybody worked with administrative data in here? So quite a few. What administrative database have you worked with?
Medicare market scan.
Medicare market scan.
So 1917 clinic.
Okay.
Medicaid.
Medicaid. Okay. So yeah, those are the big heavy hitters. Those will be perfect examples for this. So some examples: Medicare, Medicaid, market scan. Optum, which I've been working in a lot lately, which is an interesting setup, and that is United Healthcare has all of your United Healthcare claims. Things in an ideal world like the Scandinavian healthcare systems where they monitor every patient from the start of time, which is amazing. Veterans Affairs Medical System, Kaiser has a pretty good setup for their system, even Medicaid, and to a certain extent electronic health records is moving towards administrative data with our standardization of trying to enter some things. Has anybody played an I2B2? A little bit? Yeah. So that's kind of getting at where we can start pulling things and like setting up time frames and setting up before and after. So it's trending towards that direction. So with our informatics, we'll probably start making it a little bit more standardized and practical and being able to use it. So generally what's in administrative data is your ICD-9 and ICD-10 codes now, procedure codes, your CPT codes, and this is what's correlated primarily with our cost measures, national drug codes, hospital IDs, physician IDs, and on occasion lab values and some lab information along those lines. That's the most general part. There are others. It provides the records of the care delivered per se. I don't want to say, oftentimes it's what's billed, right? So we don't know exactly what's received, but we know what was billed for. Healthcare utilization, how many primary care visits were billed for, specialists, the days in the hospitals, your number of hospitalizations, ICU visits, whether you entered through an emergency room, so different characteristics of care. And then they can also capture the costs that are billed to the payer and to the patient in different formats. They use several different mechanisms of calculating cost, total cost to the healthcare, like the societal measures of cost, costs that are captured by the patient, only what's billed. We don't know some of the other costs that surround the care, but we can capture what's available within the claims. Benefits, large sample sizes. This is especially helpful for when you have diseases or outcomes that are particularly rare and you're trying to capture quite a bit of information. Relatively cost efficient. I'll give you some background. I know Gabrielle's had the same thing as I've had. It can be expensive. You know, you can end up coughing up $40,000 for not that much data very quickly. It does not require active participation. So in terms of what we would think would be easy for our IRB. It should be easy and efficient to get through. It's not a lot of, you're not using consenting participants. And it does capture health system data much more efficiently than self-report. So you can see what's happening in your overall system, as opposed to kind of getting information from others about how their system is operating, which is what's not in administrative data. Health behaviors, typically is not going, you're not going to find that. And so where this comes into play is important factors like alcohol and smoking, which are two big indicators. There are proxy measures that you can try to come up with, like whether so I can give you an example in the lung cancer data that I'm working in now. Obviously, most of this is going to be smoking related. Well, only 30% of the people in my claims had any sort of diagnosis code for whether a provider spoke with them about smoking. That's not accurate. There's no way that there's only 30% of the people are smoking. But we can kind of say, okay, let's say 90% of the people had smoked at some point, but 30% had seen a healthcare provider and that had come up in discussion. So maybe that is a different subgroup of smokers. So there's different ways you can kind of get around proxy measures and thinking about that. Patient-reported outcomes are usually not present in administrative data. Detailed socioeconomic and sociodemographic data. This is better in some databases and worse in others. There are, again, proxy measures you can think about. In Medicare, we can use whether they have state buy-in for Medicaid dual eligibility in addition to their census tract information. It's not perfect, but you're getting at some level of poverty level. And then healthcare utilization that is not reimbursed for. So I'll use cancer again as an example. If we're trying to capture whether people are discussing with their physicians about their survivorship care plans, we're not going to pick that up in administrative claims. We're not going to find whether that sort of, discussion or evaluation clinic visit was set up. So you're not going to be able to capture whether those things occur. Medical history outside of the health system coverage. So anything that's not captured in the claims that was not under their coverage period, you won't know about. So if they fall out of Medicare coverage for 2 months or, they go and they don't do something within the healthcare system, you don't know what they've been doing. And then some claims may be suppressed. In some cases, there's bundled payments for things. So you may see, this is often in surgeries, if you have inpatient care, you don't pick up the second two, whether they went to the second 2 office visits that were bundled within that visit. And then research quality lab measurements. The lab measurements are not perfect within Medicare or Medicaid or any of these administrative claims, so that's something to keep in mind. And then one of the others that we've kind of run into several times is it would be so helpful if we knew whether some of these patients were on clinical trials. There's very limited data on that, so when you're especially looking at coming up with all of these new drug regimens and immunotherapy for cancer, let's say, we want to know whether they're participating on a clinical trial because that's going to affect whether we include them in our outcomes for some other treatments that they've been receiving. So that would be helpful. There are some modifier codes for it. The HCPCS have modifiers, but it's not entirely accurate. So that's can be a problem. One of the best methods to kind of supplement administrative is to have a linked database. And this is basically, if in any capacity, it can be patient report, it can be extra lab values, it can be any other additional information that can be linked with your administrative data that can help supplement. And it can give you the best of both worlds, but there is often a lot of non-overlap, so you have to be very careful. Some of the linked to admin data, Optum provides several different views that have some different that have some different options in linked data that you can get. Regards that we have here at UAB, linked with Medicare. And then the National Center for Health Statistics has linked with Medicare for several different population-based surveys in Medicare. So there's quite a few now that are out. It is, again, they're always going to be a process to get, but Medicare has linked with all of these surveys. So we can talk more about how to get access to this, but there are quite a few out there that have some availability in terms of linked that are publicly available for you to get. Not free, but publicly available. So just to give you an idea, I don't know if you can see I'll just give you an example of, this is the Optum Labs data warehouse. So they have some linked data sets now, right? So they have their insurance claims from United, and you can choose a different view when you're working with them. So let's say you want to use their, let's say their unified view. You can get that first view. You can also get their health risk assessment within that. And then you also get access to more specific income levels. You get their mortality data. You get the oncology management survey, some lab results, and the EHR data. But they take out other factors. So they take out other sections of the data to keep it de-identified. So it's never perfect. So we've currently been working in the socioeconomic status one, which is good for our purposes because we're looking at cost differences. But the problem is now we're limited on mortality data. So we have to only use inpatient claims for deaths as whether someone died or not. So again, there's drawbacks. So if you're using linked data sets and they're trying to retain de-identified status, you're going to have to weigh the pros and cons of what you're getting and what you're choosing. Emily had laid out, I have not worked in regards to Medicare before, but Emily had laid out kind of a very clear picture of what I thought is so true when you get all excited when you have a linked data set and you're like, yes, I have 30,000 people and I can link them to a survey and this is going to be great. So Regards has approximately 30,000 black and white men and women across the United States, and they linked them with Medicare with Social Security number and then confirmed with birthday and sex. So to give you an idea, you start with that 30,000 and this is how quickly it trickles down. You have to start with linkages, so you're starting to exclude people without the Social Security number and then without matching beneficiaries, so you're already down about 8,000 patients, and then you exclude them without a record within the summary file, you're down another 1,000, and then you're always going to have these conflicting weird dates, so you're going to have to throw those people out too. And then you end up excluding people whose timeline doesn't match up, which is often a problem with linked data sets, is if when they're getting surveys and when they're not. So then that's another 7,000 gone, and then you exclude them who don't have coverage, which is a very common thing with administrative data sets. And then if you have to find enrollment before the visit, so you have to set your timeline beforehand, and now you're down to 628 patients out of 30,000. So it's very quickly, this is very true for all linked data sets if it's not designed that way up front, let's say, which is hard to do with capturing insurance claims over time. But what are linked data sets good for? They're very good at supplementing self-reported event detection. So if someone's reporting that if they've had 2 MIs in there, like as a comorbidity, and you can look back in their claims and you can verify, okay, yes, this group has had that. And you can, it's good at defining conditions and creating prediction models. It allows you to compare drugs prescribed, and then this is to drugs filled and taken. So you can get whether they've been prescribed and picked up versus whether they've been someone's self-reported adherence to it. So that's helpful in terms of taking drugs. And then it's also helpful in healthcare utilization and costs. So one of the trickier parts and probably the most time-consuming is going to be putting together a usable database using administrative claims. It's very rewarding when you put it together. It's very satisfying, but it's very, very time-consuming and takes a lot of thought up front. So when you think about your traditional database, when you're setting up your study, you have basically your patient population and your covariates that you want to consider, let's say age, race, sex, whether they've had diabetes or a history of heart disease, and then your outcome is going to be how long it takes for them to develop heart disease after your study period. When you're doing this you essentially merge your covariate data set with your exposure data set, and then you're going to exclude everybody who's had a prior cardiovascular disease, and then you'll conduct your analysis and see how those risk factors play into having new heart disease. Fairly straightforward. With claims, this is essentially you set up that type of data set within multiple stacks of data. They're set up to facilitate payment across multiple sites of care and multiple visits of care. What we're going to show you here is just kind of an idea of what it might look like and how the data is set up. ResDAC Online and the Chronic Conditions Warehouse, Data Warehouse, have some pretty good documentation. ResDAC has some really good documentation, I would say, on if you really want to see videos of how the data is laid out. It's pretty helpful. So when you have a beneficiary summary file, you're saying, so if I go in and I say I want everybody diagnosed with colon cancer between 2002 and 2004, they're going to give me a flat file with, there's 9 patients, right? So it's going to be a flat file, one line per person, and it's going to give you basic information about those individuals, right? Their date of birth, their race, sex, information like that. And then they're going to give you inpatient claims file. So each person, if they have 3 hospitalizations over the time frame you requested, they're going to have 3 records per patient. And then each visit's going to have an ID attached to it, and then a start and an end date for when that happened. And then the diagnoses attached to that visit, as well as the procedures attached to that visit. Outpatient claims is a similar structure. It's usually much larger than your inpatient file because the outpatient claims and the carrier files are able to capture services, not just the actual visit. So individual services are tracked, so you'll have, so if they've had 5 different services per claim, then they'll be laid out per person, same idea with each diagnosis attached to that claim and the dates attached. So you can see this starts to get bigger and bigger and bigger and bigger, and then you have to somehow merge all of these together and make something very pretty. When you build an analytic data set, your first order of business, other than knowing who you're looking at, is specifying your entry date or the date of the event. So when does your study period start? And then you have to have your cohort entry criteria. And this is something not to take lightly and to spend a lot of time on and testing and verifying with the people that you're working with and whoever you're publishing with and whoever is going to be a co-author. Because if this changes after you've done your analysis, it's going to break your heart. It's going to be very devastating. So you want to lay out very specifically what you want. And let's say we want them to have coverage for all of 2008 in this example. They must not have, they can't be a part of another organization that we don't have the information on. So if they join an HMO and they're also covered under Medicare, that means we don't know what happens when they use the HMO though. So now we lose that data, so we can't capture them anymore. We need them to be living in the U.S. and they can't have a diagnosis or procedure code for that history of heart disease in the year prior. And then we want them to be 66 because we need that 1 year prior of Medicare data based on that date, and less than 110 to keep some validity in terms of we want them to not be, sometimes Medicare misses their death capture, right? So after 110 you're assuming that they should be pretty close to death, if not already. And then you're going to define your exposure definition. And these are essentially, you're going to say, let's say if we're looking at diabetes, you're going to want at least 1 inpatient claim, or you can have 2 outpatient claims in 2008 based on these ICD-9 codes here. Don't reinvent the wheel when you're working with administrative claims. There's a lot of papers published out there with validated algorithms for picking up claims. If you're working in Medicare, I would recommend using their suggested chronic conditions warehouse, their different definitions of picking up different conditions, because you will have to justify why you've used what you've used. If you go off and use a different definition compared to someone else, it's going to make for a lot of explanation when you go to submit your paper. And then you'll have to specify your covariate definitions, which can be very straightforward, defining their age, their race, sex, and then some are going to be more complex, much like identifying diabetes. You're going to have to construct comorbidity scores, which one's most appropriate for your data set and your age range, identifying any other conditions, maybe creating that proxy measure of Medicaid status that we talked about. So some of them can be a little bit more time consuming. And then you want to specify your case definition. And so for an incident heart cardiovascular event, they're saying inpatient claim with a diagnosis code for MI, an inpatient claim with a procedure code for PCI, an inpatient claim with a procedure code for CABG, and then outpatient claim with a procedure code for PCI. These are, again, things you want to make sure you're clear about up front, but don't be surprised when you submit a paper if they ask you to do it 3 or 4 different ways as a sensitivity analysis. That's not uncommon. They're going to say, well, what happens if you only look at inpatient only? What if you exclude anybody with outpatient? What if you exclude this? That just happened to me on a recent submission, was they wanted to know, does this hold up under different definitions? And then you want to specify your follow-up rules. So you want to follow up, you want to be very clear about, you want to know when that event happens. So if they have an incident event, if they die, if they end up losing Medicare coverage, so they drop off in that case, if they move out, or if it reaches your study end period, right? So defining your endpoints is important. And this leads you to different methodologies to be able to analyze this information. And then building this obviously takes quite a bit of programming work. It's worth the time to spend to learn how to do it and to understand it, especially if you think you're going to be using it for a long time in the future. I would not consider just relying on, giving it to a peer group and saying, okay, you guys help me out. If you understand it as you're doing it and you can see what they're doing, it makes your questions much more meaningful and it makes the analysis much easier down the line. And then you want to review your data set iteratively as you go to make sure that you're not missing huge chunks of people if you're getting what's expected, right? So if you're checking to make sure that things look consistent with the literature to a certain extent, you want to make sure that things aren't too low, that you're missing a diagnosis code if you're missing a procedure code, and then or you're over capturing, right? Or if maybe you only put in one inpatient claim and you realize you have a much higher frequency of heart disease compared to what someone else is showing. And then at this point, once you've created this database, now you can actually run your analysis. So it takes a while to set up. This is just another schematic to think about setting up a data set. If the idea here is to look at healthcare use after treatment, then you have to kind of think about how you want to set this up. And from an administrative database standpoint, let's say we want to know what their healthcare use was prior, but that means I need to know their comorbidities prior, so I need to set up my prior point, and then I have my diagnoses, and then I have to define, let's say, okay, what qualifies as ending treatment? And then so that's dependent on which disease, so I'll qualify what of an end treatment, and then I want to identify their healthcare use down the line. But I don't have hospice claims, so now I have to stop my follow-up 6 months prior to death because I won't have the hospice claims to pick up what's happening to them. So there's just different things to think about what you have access to and what you're working with about how you want to set up your data.
I would ask you a question
Sure.
operationally. This has been really informative and instructive. I'm just trying to think through, for someone that's just getting into this, can be kind of daunting thinking about trying to engage any of these databases. So this is just operationally, do you know other contacts or a place where, for Medicare, Medicaid, I would think Meredith, Kilgore, that there's different groups. So just trying to think about when you put so much upfront time into learning one of these databases, is there an institutional memory? And maybe, just trying to think about how we might collate that and have that, whether it's in the CCTS or somewhere, so that, like you've done all this work with cancer, someone else, how do we create some structure where someone doesn't then recreate the wheel and figure out? So
Peer has done a really good job of the peer group website and UAB peer group, right? Is that it? Yeah. They've done a pretty good job of basically documenting and uploading majority of they have a lot of available streamlined code that can help. It depends on how you work. If you want to try on your own and then go back and see how you know what I mean, see how your logic flows go with theirs. Because I do think people work in different ways, but peer group definitely has done, I would say, probably the most work in terms of having access, they've come up with large structures of how to manage Medicare, Medicaid, and then putting it up there. So there is access to that, and they will help you with it.
That's great. And then the regards would be the Howards. I'm just trying to think about, would it be nice for us to
For regards Medicare, it's me.
You have, okay, I didn't know who was, yeah. I'm just trying to think about just compiling and collating because, and like to your point of, if there's a standard definition for diabetes in whether it's regards or whatever data set, like having that code and knowing that would just be a wonderful resource.
Yeah.
We also, for SEER Medicare, have a group that meets monthly that, sort of, it's a little bit informal, but, we ask questions and sort of shoot each other emails and say, hey, how do you do this? Or I'm having a problem with this, which I think trainees could potentially come to as well.
Yeah, and like, let's say I was trying to figure out a new way to do a radiation. So I asked Courtney, I'm like, hey, Courtney, have you already done that? Can you send it? And I didn't end up using what she did, but I was like, okay, I see what she's doing, but that's not what you know what I mean? But it helps. It gives you a baseline of whether you're.
Would it be valuable for us either through the core or CCTS to try to reach out to different groups and have some home with links and connections? I'm just trying to think about operationally. If I'm a new person to UAB wanting to do work in cancer or do work in diabetes, and with collating that and know, okay, I've got to go meet Dr. Levitan.
We can, I think that if there's interest from the CCTS or putting a linkage page out there, the peer group has, I think we can link to the peer group. I have spent a good bit of time putting that website together. The other thing that we have, in addition to the SEER Medicare working group, is that there's the peer analyst meeting, but anyone is invited to, if you're working with this data. And so that's monthly, and there's lunch, and, the people who are, we get some of the programming for this, we'll get together and share tips and strategies and that sort of thing. So I think, we can put that up there too, with information about how to get on the mailing list.
Okay.
In terms of coming up with more, I don't know, you guys can speak to this too, more sort of technical documentation about which codes and all that, we've gone back and forth. So we'll be like, okay, here's our definition, and then we'll come up with some good reason why in our next project we're not going to use that definition. So I think that gets a little trickier.
I think the peer group itself has enough, but I don't know that I would spend effort to redo any of that. But I think more making that more aware, people more aware of that is probably be helpful.
I'm thinking more of almost a matchmaking service. So having a place where we would say, if you're want to do work with this data set, connect with peer in this point of contact. If you want to do work with SEER or cancer, here would be more of that matchmaking.
Yeah.
The only thing I would sort of caution against is sort of just going in there and pulling off the code. Because like Kelly said, I think there's a lot of value to going through it yourself and getting that experience and then looking at that sort of when you get stuck or when you need backup.
Yeah. It's definitely helpful to see. I think it's more the logic flow.
Yeah.
That's the important part. It's more the learning how to understand why someone did something a certain way and why you either need to do it that way or if there's justification for not.
Yeah.
So that's
doing that very
purposefully and and it helps. And again, it helps when if you're working with other people that have worked with it before. So it would help in terms of a matchmaking service, right? Like if you work with it, if someone explains to me why they want to do it that's great. Do it that way. This is just kind of a big overview. Again, documentation, why you want to write a good analysis plan, so you have those documentation of why you made those decisions. So when you go to write the paper, that you remember why you did it. And then it helps with logic for building data sets, communication with a statistician if you're working with one, and then it helps prevent wandering, like if you happen to find something really cool, it kind of keeps you in line and keeps you in check on your purpose. Tips for using this generally. Remember why and how the data were collected. Can you answer it with your data if you are thinking about your research question? It may be really great, but we were just talking about some data sets, if you're missing mortality, that could be really problematic if your outcome is mortality. So I would think about that. And you're always going to need a before time for defining a lot of the variables, baseline or look back. So think about that both in requesting the data, timelines related to, let's say you have a really big interest in the implementation of some guideline and you are like, oh cool, I have this data set, but then they only have the years available to you that are not compatible with that guideline. So you need to make sure you have your study fits in the time period that you have available to you. And then you want to create an analysis data set with the knowledge that you are going to invest a large amount of time in it. It is not a quick process. It's very iterative. I would work closely with people in making what seem like small decisions up front because it's hard. It's not hard to go. Obviously, you can go back, but it's just very time consuming because they're typically large data sets, and it's not an easy task, and it's better to address those things up front. Plan for a lot of sensitivity analyses. That is probably my biggest realization. Based on your exclusion criteria, if you're kicking people out for a certain reason, what if you put them back in, or what do they look like? What does their population look like? You at least have to describe them. The time frame, if you are saying, okay, I'm looking at a 10-year period, what if you only looked at 5 years? What does it look at 5 years? And I'm not saying these in an exploratory sense. I'm saying that these are often reviewer questions. These are going to be questions you'll get from people who want to publish with you and are saying, but they're arguing for a certain time frame change or something like that. Your different covariate definitions and outcome definitions. Again, inpatient only. What if we just use outpatient? Things like that. So this is the logistical part, the process to obtain it. First bullet is if you are trying to obtain this yourself, if you are saying, okay, I'm going to go out and I want to purchase this data and get this on my own. You do have to do an IRB. It's typically exempt if it's de-identified, and that can take, I would say, depending on I don't even want to give a ballpark, because if you do not have to go through a working group or a different study subgroup, that can only take 3 or 4 weeks in IRB. But let's say for cancer, we have to go through 2 other extra working groups, so it takes about 8 to 12 weeks. So it depends. I'm not sure about everybody's individual departments, or so I want to speak to that. But you do have to go through an IRB process. It's typically exempt if it's a de-identified data set. And then typically for all of these, it doesn't matter, it's across the board. Even if you're working internally, you are going to have to come up with some sort of application. You need to give your idea, and what you're going to have to do is you're going to say what years you want, if you're picking a certain disease, or if it is or a disease type or subgroup, you're going to have to give the time frame, the variables, how you're going to define them, what analyses you're going to do. So pretty much up front, before you even obtain the data, you're going to have to come up with some sort of application or proposal. And then there's always a DUA for it, a data use agreement. So something to think about is, okay, that's great, you're going to get all this data, and this can be tricky as a fellow. I know that you need to have a home for the data, so you need to have a storage server and somewhere to put it. So those are considerations to think about, whether you can keep it, because it can't be held on like a personal hard drive. It has to be in a secure capacity. Most of our departments have storage network servers. Peer Group offers storage on their server that you can get access to, that you can kind of have your own folder, right? It's like your own folder or whatever. So, so I keep mine on the PED server over in Children's. So you have to come up with some sort of storage agreement and sign that, and then whoever else is going to be touching the data. So if you have a statistician, they need to be involved. So can they get access to your storage server? And then I only added in contract because UAB recently changed some of their policies, that if you're buying data, that we now have to have contracts for people, and so that took me an extra 4 to 6 weeks or so to, I don't know, do that, I guess. So that's through your business office, and you have to set up a purchase contract, and then you can go through your purchasing process, however that goes through, for whatever whatever mechanism you're going through, and then they'll either ship you data or have a download source, and you'll have to unzip and typically decrypt the data that they've given you, and then you'll put it on whatever storage server you want. That's going through it from, you look online and you want the NHANES linked with Medicare, and so you fill out, there's every single one of these, you click on them, they have very detailed instructions about how you're going to get their data. So you can go through that. And alternatively, like we were just talking about, there's a lot of people here that have data. There's a lot of investigators here that are working with MarketScan, Medicare, Medicaid, the Regards Medicare. So there is a lot of availability. Peer group is one great resource to get access to some of the Medicare and Medicaid data. Dr. Jeff Curtis, he reached out and wanted me to make sure I discussed MarketScan because that is definitely open to investigators' proposals. They would really like more collaborators. It's good for access. It's a really great resource, especially if you're a fellow, to get access to that because that's very helpful and gives you a lot of data to work with. And then on the flip side, it helps them retain funding, right? So it's a win-win for both parties. So there are limitations though, so I don't want a blanket statement.
I was just saying one quick plug for MarketScan. It is enormous. So we just pulled our metastatic breast cancer patients, and it's like a order of magnitude more than what we had in Medicare.
Yeah, so Medicare is obviously 65 and older, right, or for the most part. The age range is 18?
MarketScan is private insurance.
Yes, private insurance.
It's, it's not necessarily an older adult.
Yes.
It's not an older adult.
Yeah, you get your younger
population. We're just starting to work in it now, but it is very large and I think has some advantages.
Yeah.
This speaks to, I think, an opportunity for more organization and collation because I think a lot of folks don't know. If you didn't come and mention Jeff and MarketScan, and many times there are institutional licenses, so it just seems like we could better advertise and have a place to let folks know. Because the same thing, if someone already has an institutional license for NHANES or something else, when you describe that entire top row and the activation energy and time that someone has to invest, if it's already been done and it's tapping into, you saved yourself months, right? I mean, months in terms of your project.
Yeah. The only drawback, the limitations that I wanted to make sure is that I know that, so let's say Gabrielle and I have SEER Medicare data. When we put in our proposals for that, you have to state what you're doing with the data. So you can't just have, you have limited flexibility in terms of, as much as I would love to be like, oh, you have a really cool project you want to do on hospital, whatever, like something to do with like the hospital level costs related to something, and it's not in my proposal, you can't do that with my data. They won't let you. That's how they make money, right? If they let you just pivot off of your project, they would never make any money because the data would just be everywhere. So there are limitations in terms of some of the types of data set. Now MarketScan, it's an open book. You guys can go for it. I think Medicaid is pretty flexible. The Medicaid data we have, are they not in terms of what?
I mean, so Medicaid is if you're working with Alabama Medicaid, they're a little, I mean, you have to get permission to do every single
Yeah, you have to get
but they're not nearly as formal as like CMS.
Okay, yeah.
Or,
like once you
just kind of call them and they're like, oh yeah, write this up. And then like,
yeah, you have to get approval for it, but you don't like we're bound to whatever we put in for SEER Medicare. So we're not allowed, we can try to make it work, we're not against that for sure, but there are limitations in terms of how far off the rails you can go. And then some of them are sort of locked in terms of like, let's say, like the Optum we're working with right now, the way we have it set up, we're going to try to expand it to make it a more open concept, but like the way we have it now, it's the way it's funded, we can't even have other people work on our specific Optum data set. Like there's no option to even work outside of it. So there's just different limitations pending which setup you have and what are the rules of that organization. And then this is just a side note. This was actually that peer analyst meeting that Emily brought up. They just had a big presentation on the ICD-9 to ICD-10 conversion, which if you're going to be working with longitudinal data administrative claims, this is going to be, it might be a little challenging. ICD-10 is just much more specific. It's just one little example at the bottom that's commonly discussed. An ICD-9 for a closed fracture of the shaft humerus is that sort of 5-digit number at the bottom, and then the ICD-10 is now very specific, giving you where it's happening, how it happened. It's very like which arm it is. So it's just a lot more specific. There's not always going to be a perfect match between ICD-9 and ICD-10, which will be a little problematic for administrative claims people in the future. They're coming up with linkages and algorithms, and I know Peer has access to a lot of that. and is working on it as well internally. So that's just a consideration looking at this stuff long term, depending on how far back your data is going to go. Okay, questions? It was just kind of a lot of information.
I'm wondering about, say there's a scholar coming in
Mhm.
who is a clinician, working farther down the translational line. They're thinking about doing a project, and it would really inform their study design in a prospective way to look at one of these
Yeah, for
databases.
sure.
Is there, and forgive me if this is an obvious question I just don't know the answer to, but at the School of Public Health or something, is there a center for epidemiology where they could go and say, hey, I'm not an epidemiologist, but I'd love to link up with someone who could help me explore this database?
So there's two parts to that. One is from a methods perspective. If you're just talking methods, I know that we have a little bit of that in the CCTS, but the other side of it is that it is a very you do have to have programming skills to be, if you theoretically really want them to look into the data, and that's a whole different animal. Does that make sense? So oftentimes you can get both, but sometimes you're just going to get one or the other. You can get a programmer who can give you what you want in terms of, okay, this is how much data you have, and this is what it is. But then there's the methods part of it, which is theoretically, how do we design and answer this question? So sometimes you can get both, sometimes it comes in two parts. I know we have the CCTS biostats group.
Yeah.
I don't know how oriented they are to claims. I'm not sure. Has anybody worked with them in terms of claims?
I think the challenge is that, as Kelly mentioned before, it takes a lot of time sort of in the data from a programming and analyst perspective, and so unless you have some ability to pay somebody to do some of that work, that's not the kind of thing that somebody can be like, oh, I'll help you out and just do this, because it does take a long time.
Well, now I'll say I think to that question, we have just started with our T32 postdocs doing these tips panels, which are meant to be not works in progress, but moving into implementation. So part of the objective with those type of panels is to exactly say that. So here's a question you have, here's the data set or other data sets, and not that we can provide it for you, but might we connect you with the peer group or with whoever the right group is. And then there's always the question of resource. So then is there within the training grant or elsewhere resource? But I think that's one way operationally we're trying within the T32 with our T32 to achieve that type of connection.
So I think, ITV2 is really set up for people to sort of go in and play with it for themselves. And so I think that is a good resource, if you don't have sort of the stat skills or the money to pay somebody who has the stat skills, like has stats and programming skills. There are ongoing projects and there are, investigators and a really, really good team of statisticians and programmers who can, manage this, located in a couple of different pockets across campus. So, there is a possibility to collaborate, but, I think when we priced this out, when we were trying to figure out, because I think we were like, okay, yeah, we're going to offer this, and then when we priced it out, it turns out to be not cheap, right? So one paper, so we estimated that, for one of our statisticians, they could do about 3 papers a year. And so, you're thinking about paying a third effort for a statistician. So that's not cheap, and that's hard to absorb in terms of, where that money would come from.
So I think one other plug is it is good to have those people, even if they're clinicians, do it themselves at least once, so, I no longer spend a ton of time programming. I'm not that good, but I did it, once as part of a career development award, and it was one of the best things I ever did. Not because I'm doing it all the time, but because I can now sit down and look at somebody's code and follow the logic, and then when something doesn't make sense, I have the ability to say, this is probably why it maybe doesn't make sense from a clinical perspective. So there is a huge amount of value in actually doing some of that SAS coding, or a lot of it actually, I think, yourself for somebody that is kind of earlier in the pipeline.
Okay, you've got an orange message. Maybe that's a question.
Good job, Eve. Mommy, an orange message. That's in the back row.
Just a hypothetical. It was more or less just, let's say you're doing a defined group where you have, you pick stage 1 colorectal cancer patients. You wouldn't typically try to do it at the end of hormone, like you wouldn't use long-term, a disease with long-term implications like that for that particular model, if that makes sense.
So this is just a thought along the lines of the discussion that we've been having. I think there is a lot of value in connecting, having some place to connect people to either experts with particular data sets or resources. I think there seems to be a lot of expertise in certain areas like cancer research or, with the regards data, but so I've used National Center for Health Statistics vital records data from birth records, and they have a lot of different options for linked data sets. And so I'm aware of experts in maternal and child health and HCOP who use that data, who have been able to go to, but I just wonder if other trainees were interested in that data, if they would be aware, who. And if there are other people maybe I'm not aware of that I should be connecting with across campus is something that I've thought of as we're having this discussion. So I don't know if that's always as visible across campus.
Yeah.
And I would say what's done under either the core CCTS banners, our responsibility, in part, if that's something that's important and valued, to try to collate that information and make it more available. So I think an action step for John and me and Emily from this is to kind of try to follow up on that. If it's something that would be of value to the broader, I think beyond T and K training community, I think there's probably folks even, across the career spectrum that would benefit from knowing, oh wow, I didn't realize that Jeff Curtis had access to market scan and what's in market scan that I could really use.
And that it's actually readily available.
And not so much for those of us that are doing this sort of day-to-day, but I feel like it would be a great resource for the trainees if you guys, could hire out or pay some of like an analyst time to sit down with somebody, who is early on and kind of troubleshoot the code if there was some concentrated support for that for trainees.
No, I think it's a great point, and I think it's something, it's an evolution, and I think something that we're trying to do. And it's hard in terms of resource and how much time and effort and where the funds come from, but I think it's a point well taken, something we're trying to do in terms of thinking about regulatory time, data analyst time, and biostats epi time, and if we could get some amount of that for especially, early, T scholars, that they could really get a really great return for them in terms of scholarship and success. So it's we're trying to, operationally, but it's something I think we're invested in doing, and iterative feedback from this group will be critical as we're trying things and saying, is it working or not working? Is it meeting your needs? It's going to be critical as we iterate. And the money is, you can find it, and then how do you sustain it? So I think it's important that, we're institutionally very invested in all of our T and K scholars, so it's, finding the right folks to sustain.
It is very helpful if you are doing fellows work and you have a concentrated timeline. As one of your projects, picking to work in a larger database it's a good thing to have on it's a good publication to have because there shows that you can think through that sort of, even if it's not going to be your long-term thing, it's definitely a good skill to learn, and to learn then down the line when you're reading papers how to judge them as well and how to evaluate it. So.
I agree.
Even if it's not going to be your main thing, it's worth it to work on one.
I totally, the general advice that I give, I totally agree, it's really valuable, to do at least 2 projects, not get over, and one that is a secondary analysis of existing data, and one that's primary data. So in terms of during your training, the value of both of those,
I worked on behavioral intervention trials and big data, and turns out I like big data.
Something else that comes up is sometimes the databases aren't even things you would think about. So, when I first started doing work and looking at kind of visit data, one of our data analysts said, we don't want to use the EHR. IDX, it's IDX. IDX is this administrative filling database, and it's a gold mine. I mean, beyond just capturing visit data, hospitalization, ED visits, there's a wealth of data. So sometimes the administration